Before we start, just one quick piece of housekeeping. I know that there is a resident presentation next week. I will not be able to attend that. I'm actually out of the office on Thursday and Friday of next week. I apologize, but I won't be able to attend.
Hey, Dr. Tobia, just for clarification, for the resident presentation next week, so is that a journal club?
No, actually, well, it could be. It could take any form the resident wishes. The only restriction put on this is that I ask that the resident not simply create a PowerPoint reviewing psychopathology and maybe even psychopharmacology. So some creativity has to be involved, but otherwise, it really could take any form whatsoever.
Okay, thank you.
So that would definitely include a journal club, but I want to fall short of saying that you must do a journal club or create a journal club-like experience. So for purposes of today, how do we want to go about things? Have the residents selected who's going to be doing what for the podcast?
So Mark, Ram, and I are up for this week. We had kind of decided we'll just kind of let it flow organically and not divvy up like different parts of like psychosis, depression.
Even though this week's or this month's topic is schizophrenia and other psychotic disorders, and I think our objective would be to include those disorders in our discussion today, and of course then in the residents' presentation next week as well. I don't want the residents to feel that that's the only thing they have to discuss. They should feel 100% comfortable discussing what they truly believe this story was about, and that includes the selection of the character they wish to evaluate. Right? Who in your mind is presenting to clinical attention? Again, this goes anywhere you'd like, but at the end of the hour, the hope is that we would have at least covered that chapter of the DSM, specifically schizophrenia and other psychotic disorders. So necessary, but not sufficient. With that, where would you like to start?
So I guess since the whole story is from Paul Edgecombe's perspective, we could kind of think about him as maybe being the patient, maybe, since really it's all from his perspective as a supposedly a 100-some-year-old man. But kind of we're taught whenever we hear something that seems too fantastical to be true, then we're kind of dealing with the bizarre delusions and hallucinations. So that's where I was thinking we started. I don't know if anyone else wanted it.
Yeah, I think that makes perfect sense.
Sure. It's interesting because even though it was one of the final things disclosed in this film, in clinical practice, it may literally be the first thing that you hear. If it's from the triage nurse, that the patient reports that, in this case, he is 118, or even when the initial evaluation is done, medical student resident, 118-year-old patient who appears his stated age, or in this case, does not appear his stated age. So it is one of the first pieces of information that you actually gather. And the other part of this too is, of course, the way Stephen King, or at least this adaptation of King's novel, plays out. We are kind of spoon-fed who the patient is going to be. This is a narrative. This is a patient's story. Doesn't present the clinical attention per se, but you could have just as easily been the psychiatrist staffing that nursing home. So very straightforward. terms of how this begins to unfold. All right, so what are you going to do with our 118-year-old patient? Where do we go from here?
Well, so it's tough because all these things happened years ago. So in terms of it almost seems like a fixed delusion that happened all these years ago. He he really it seems like there's no getting past that part, but he doesn't seem to be. It doesn't really seem to be affecting him currently. Although he's probably hallucinating this Mr. Jingles mouse still, and sharing his bizarre delusions with others. I wonder if he is if the nursing home is a nursing home, and maybe it's a psychiatric hospital, and maybe he's been on antipsychotic medications, and they're kind of working to a certain degree, but then the parts in the past, they, as we deal with some patients, sometimes they never get over that fixed delusion, and you can kind of help them from hallucinating in the future and having mental illness or another like episode where they need hospitalization, but sometimes those delusions are too fixed and not even the antipsychotics can cut it.
I honestly would have to rewatch this film, and you guys have heard me say this more than once, that when an observation like Mark's is posed, going back and rewatching this film now with that in mind provides a completely different perspective. I mean, we're actually looking for this evidence to be verified rather than just sitting back, relaxing, and watching a movie. This film is a little painful in that respect because it's well over 2 hours. So simply stating, well, we'll just go back and rewatch for this evidence. I like the idea that he is not in a nursing home and perhaps is in a psychiatric facility. And I believe minutes prior to disclosing that he's 118 years of age, we do see a shot of a psychiatric facility, albeit one in his mind. His peer is being escorted to, right? And it does make you kind of pause as to whether or not that memory is a false memory. That memory is perhaps confabulation, that it is he, Paul, that was transferred to that very facility that we see in about a 3 or 4 second screenshot. Again, I'd have to rewatch to really get how many seconds prior to the disclosure of his age the picture of that psych facility is brought to our attention. Observation that there's questionable clinical significance. So I do have a point to make about that, but first want to ask your thoughts, anyone's thoughts about whether or not Paul appears to demonstrate clinically significant distress or impairment.
Well, I think in regard to the somatic complaints that he has, like with the urine dysuria, I mean, I wouldn't call it like an overt impairment functioning because he's still at work, but he is having significant distress over his urinary issues. But I guess from like a medical kind of perspective, like, is it like a urinary tract infection? Could he possibly even have like an STD? We don't know, but that was something that came to mind for me.
Any thoughts on that?
I thought he was in like uroseptic shock, and then he was actually hallucinating everything.
Yeah, we actually brought that idea up in yesterday's seminar at the Center of Alcohol Studies, that individuals who are delirious have a very difficult time establishing timeframes. And this is something that is shared with individuals afflicted with major neurocognitive disorder, aka dementia. When you talk to someone who has Alzheimer's disease or dementia of the Alzheimer's type, they may speak about a deceased spouse as if they just spoke to them. And it's usually their children, their son or their daughter, that will remind them, Mom, Dad's been dead for years now. So establishing timeframes is difficult in both dementia and delirium. And if you add on UTI, rule out urosepsis, or even a tertiary syphilis or another STD, that certainly could be something that needs to be investigated, right? Organic pathology, underlying medical condition, as to why someone like this might report their age at 118. So rule out delirium. That could be delirium superimposed on a baseline major neurocognitive disorder as well.
Yeah, I think some additional points for major neurocognitive disorder, perhaps Lewy body dementia of some sort, would be just the fact that he was having some visual hallucinations of the mouse, if we're talking about the end part of the movie. And then one more thing that kind of stuck out to me, kind of, agreeing with Mark here, with that thought of maybe they're in a psychiatric facility. At the end, when he's, I guess throughout the entire film, when he's having the discussion with Elaine, I believe is her name, the other old lady that kind of, stepped out with him initially at the start of the movie, and then he explained the entire movie to her and then showed her the mouse at the end, and kind of, the entire conclusion. It might be a flawed, like a shared psychotic disorder, like a shared delusion between the two of them, which I think, I mean, it's quite rare from my limited reading, but I think there's not that many case reports. But I mean, if it's happening anywhere, it would probably be in a psychiatric facility between two people that are maybe staying there for quite a while. So I'm not sure.
So, certainly something to investigate. I mean, from Elaine's perspective, she seems to choose her words very carefully. At least my first instinct is that character is not delusional, but seems to want to support her friend, while not necessarily contributing to his current state of mind. So we don't really get to see much of her, and of course, we really don't, or we're not provided information that would really allow us a comprehensive evaluation, far short of that. But she does seem, at least at first glance, to have some level of insight. And she does choose her words very carefully. She articulates them well. So I'm not so sure that this is someone who is struggling with a similar condition that is dementia. That certainly Paul may be afflicted with.
I think jumping off Ram's point about the shared psychosis, shared delusions, and us talking about the time frame being off. Every prison guard, other than Percy, sees the same things Paul does at certain points, and believes that John Coffey can do all these things. And then you're talking about, decreased function. They all take him out of prison to this house, or maybe they imagine it. I'm not sure, but that would be another, set of behaviors that could be definitely dangerous and lead to him going to the psychiatric hospital to begin with. And maybe that's kind of where the jumping off point is. They do that, and actually it goes very differently, because those are really the time frames we see that, and then in the the nursing home, and no other things really covered. He says he transferred to, I forget where he transferred to, but it was no longer the Green Mile. I should probably have noted that.
And kind of going off of what Mark is saying, I agree. I think this is some sort of fixed delusion. I don't think we really know, in my mind, like how far the delusion goes. So did any of this actually happen? And did it all happen in his head? And if that's the case, then his level of functioning would be really low, I would argue. But again, if this did happen, then I think his functioning is probably a little bit higher than if, this whole thing is an actual delusion. And has he been in a hospital his entire life? And we just don't know.
Good point. Two very good points. Yep. So, along those lines now, again, I think this is going to be a matter of perspective. Remember, Paul is the one who's narrating this. We're hearing a patient's story, a patient who reports to be over 100 years of age. I would challenge whether or not these are true memories to begin with. So the idea that my peers also saw this, or when I saw it, I had two other peers standing by my side. Not even sure that's true. If we otherwise take the perspective that what we see, what the film depicts, actually did happen, I would be very interested to see and how those stories, the sequel, if you will, of those other prison guards unfold. That is, once Paul does transfer, do they improve? Do they gain insight, recognizing that what they believe to have happened was in fact a product of their mind? Because then that would certainly fit with not only the treatment of, but then the natural course of shared psychotic disorder. And of course, we don't have that information. It would be a cool YouTube video to actually create and post. Again, the stories of those prison guards upon Paul's transfer and what actually happens to them. So I want to get back to this idea of clinical significance. So there may or may not be clinical significance. Certainly, I think in clinical practice, when there is concern that there is, as a conservative clinician, you should deem the behavior problematic, clinically significant distress or impairment. Again, the idea here is in that gray area, you don't want to make the other mistake. You don't want to blow it off and say there's nothing to do here and end up finding that there is. So we might want to proceed conservatively here and think that there does seem to be evidence of clinically significant distress or impairment. Mark had also mentioned that there might be evidence of treatment at this nursing home that is somehow, or I should say a psych facility that is disguising as a nursing home. Along those lines, had anybody recalled perhaps any evidence other than Paul seeming to keep it together? Efficacy? Any evidence of side effect? Was there Parkinson's, Parkinsonian findings? Was there any postural tremor? Was there anything that we observed that might reinforce this idea that he may be on a medication here? I think we have to put in that category of this is something that deserves that rewatch, right? Really looking for those types of signs. So good luck with that. And let me know if you actually find something. So very quickly, in clinical practice and on board certifying exams, this goes by the rule of fours. So 4 hours to 4 days, the most rapid onset of side effects. Again, this is the result of lowering dopamine in areas of the brain other than the mesolimbic tract, right? So we lower it at the mesolimbic tract with your antipsychotic of choice. And by lowering it, we have improvement of positive symptoms of schizophrenia, positive symptoms of psychosis. These are symptoms that are the pathological presence of something that at baseline should not be there. Examples? Anyone? 4 major examples.
I want to clarify what 4 examples of
positive symptoms of schizophrenia or psychosis, pathological presence of something that at baseline should not be there as a result of increased dopamine levels at the level of the mesolimbic tract in the central nervous system.
So like hallucinations and delusion?
1.
Oh,
2.
Disorganized behavior, disorganized thoughts, speech. Sorry. Okay. Yeah.
Yep. That's the 4. Again, those 4 you're pulling right from the DSM criteria for schizophrenia as well as schizoaffective disorder. Those are 4 positive symptoms of psychosis and therefore defining criteria of those psychotic disorders, again, specifically schizophrenia and schizoaffective disorder. By lowering dopamine through medication at the mesolimbic tract, those symptoms will improve. However, there is no mesolimbic specific dopamine antagonist. That is, once you improve symptoms by lowering dopamine at the level of the mesolimbic tract, dopamine is also going to be lowered outside of that tract, outside of the pyramids, extrapyramidal. Hence, we're going to get extrapyramidal side effects or EPS. The most acute of which occur between 4 hours and 4 days. What is the most acute EPS?
Dystonia?
That's right. Okay, acute dystonia comes in two varieties, general and focal. General dystonia, it's the usual suspects. You treat with medications like benztropine, Benadryl, but it's focal dystonic reactions, torticollis, that require a different form of therapy. And because it's a different form, it's the one that most commonly appears on exams. What medication am I referring to?
Botox?
Excellent. After acute dystonic reactions, we have another set of reactions, EPS, from 4 days to 4 weeks. This is acute akathesia, motor restlessness. It is the most common EPS, right? So it's not the most rapid in onset, but it's the most common. Treatment?
Propranolol?
Great. After acute akathesia, we have another set. Now we're talking 4 weeks to 4 months. These include both postural tremor as well as pill rolling tremor in the context of neuroleptic or medication-induced Parkinsonism, right? So here, whether it's the tremor alone or whether that is the pill rolling tremor, or whether it's other Parkinsonian features, the onset of these side effects will be clinically indistinguishable from Parkinson's disease. Of course, the cause is different. Here, it's not the death of the cell bodies in the substantia nigra, and therefore affecting dopamine at the level of the nigrostriatal tract. It's the lowering of that dopamine in that tract through medication side effects. So medication or neuroleptic-induced Parkinsonism. But the other tremor, the postural tremor, tremor against gravity, arms extended, fingers spread, is another potential side effect that could occur between 4 weeks and 4 months. 4 months to 4 years, we have tardive dyskinesia. That is, we have chronic exposure to these medications resulting in an upregulation of dopamine receptors and therefore manifesting as potentially irreversible neurologic or hyperkinetic movements, right? So it usually starts perioral, but certainly goes beyond that, right? So it's a potentially irreversible neurological syndrome that is tardive dyskinesia, or TD. Treatment of choice is to stop the offending agent. And even though there are newer medications on the market, I still think the single best answer of neuroleptic to switch to, if you can, will be clozaril. So stop the offending agent. Now, you've got to be careful. This does require early detection, right? So AIMS scales or AIMS scores 3-4 times a year when on neuroleptic medication chronically, for chronic conditions such as schizophrenia and schizoaffective. At the earliest signs, informed consent must be part of the continued prescribing of these neuroleptic agents. And at some point, consideration should be given to switching over to clozaril. Questions about EPS, even though we are falling just short of saying that maybe we observed any of this in our patient. Okay, so we have questionable clinical significance. We're going to follow through with that. We have fixed delusions. What do we think of Paul's cognitive exam otherwise?
Well, we were talking about how he thinks you said 118, so disoriented to time, memories appear to be inaccurate. I don't know if we get much. I'd have to rewatch it. If we get much more information about his cognition, but obviously the anticholinergic effects of some of these medications over long periods of time could contribute as well.
So, anybody here happen to read the book? Me either. I wonder.
Yeah.
You don't, well, look, okay, I'm going to put you on the spot, Mark.
Years ago, though.
Well, I'll still put you on the spot. Unlike the movie where we're challenged as to whether or not we take a flashback scene, a scene of them in prison at a younger age, as what happened versus his recall of what happened. In the book, it's much different, right? In the book, it usually actually says, like in 1930 something, ... And there's no question that in the novel, Stephen King is recording and informing us of the events on the Green Mile. The movie doesn't come across like that. The movie always lends some degree of clinical suspicion, but the books don't. Do you happen to recall reading anything? Because if we opted to go by the way the book reads, this idea that he's an unreliable informant and we should have concern about deficits pertaining to memory might actually not be concerns at all.
I don't remember.
Again, I think it's reasonable that that's happened. I mean, think about this. I mean, there are a lot of books that go back in time and record events that the reader must be informed of. How frequently does that chapter begin with, as far as the patient recalls, in Derry, Maine, in 1955, there was a sighting of a clown. I mean, that's just not the way books are written. They're written much more straightforward, and it's pretty clear that that event happened. So, again, just something to consider. I don't know if there are many other cognitive deficits other than fixed delusions that we're struggling with here. Even with orientation, even though he reports that he's 118, he's quick to say, the dates don't add up. And I suspect that, and of course this doesn't happen, but I suspect that if any character or perhaps a psychiatrist that happened to step in that room would say, do you know today's date? Do you know the month? Do you know the year? I think this character has a rather good shot of getting that correct. And the report may be that he's awake and alert and oriented to person, place, and time. Again, never asked, so we really don't know. But I wouldn't be surprised if we find him fully oriented. What impact does this have in the way we're beginning to develop our differential diagnosis? What would otherwise be deemed maybe lack of clinical deficits and the sensorium perhaps being intact?
I think right off the bat, it would probably move some of the neurocognitive disorders to be a little bit lower in the differential.
Great. And what other cognitive type disorder might also be moved lower in the differential? A cognitive type disorder found in the schizophrenia and psychotic disorders chapter. Schizophrenia.
Yeah,
Right?
just because of like degeneration after numerous psychotic breaks, right?
Remember, schizophrenia was first described as a cognitive disorder, dementia praecox. Individuals with schizophrenia very rarely have a clean mental status exam with evidence only of hallucinations and or delusions. That's usually not the case. As a matter of fact, it's written in the DSM, specifically in the condition delusional disorder, that except for the impact of the delusion, clinical significance remains intact. Excuse me. I should say that functioning remains intact. And the reason why the American Psychiatric Association wrote that into the definition of delusional disorder is because of the absence of cognitive decline in that condition, especially compared to schizophrenia and schizoaffective disorder. So we're going to have to consider both of those conditions, schizophrenia and schizoaffective, but I think they're going to be much lower in our differential. And I think, relatively speaking, delusional disorder is higher. We do see an individual here with a fixed delusion But when it comes to schizophrenia, not much else. There might be hallucinations, but again, I'm not sure if we are watching a movie and just having the producer or director's intention to show us what Paul is relating as his memory versus a true visual hallucination. And even then, I would opt to say that that is not the case because visual hallucinations are very rare in schizophrenia and schizoaffective. So it really doesn't fit perfectly here. But again, we might cheat and just look at the book because, again, my hunch is that the book does not report these consistent with visual hallucinations. In the book, those scenes are likely to be reported as having happened. Right? Stephen King will take you back in time to the 1930s and have you be part of what happened in that penitentiary. So schizophrenia, schizoaffective versus delusional disorder, like any other mental disorder, schizophrenia, schizoaffective must be clinically impairing. That is clinically significant distress or impairment. Delusional disorder, that qualifier, that criterion is written just a bit differently. And it's beyond the impact of the delusion itself, functioning remains intact. And that's what we may be seeing here. Any thoughts about that in terms of these three psychotic conditions? I think one of the things we brought up earlier, and I think we need to revisit, albeit briefly, is the role of any organic ideology has on any of these, right? So before we take our next step and further discuss schizophrenia, schizoaffective, and delusional disorder, we, across all three, must rule out the direct physiologic effects of a substance or another medical condition. Medical conditions are concern here, especially given Paul's age, and especially given his reported age. We've discussed that. So this might be all due to a UTI, due to urosepsis. And I strongly agree. We really can't rule out that this is a late stage of an untreated STD, such as syphilis, such as HIV infection and AIDS, which would make this movie much more sinister. Because if we could trace this back to the 1930s, what the heck is that prison guard doing to have actually contracted an STD? We'll leave that one on the side for now, right? No conspiracy theories going that deep just yet.
Tardive, sorry, one more thought as far as the potential medical differential. I know this is probably lower down, but epilepsy as well, just for visual hallucinations and the rarity.
Yeah, you're exactly right. If we want to really go down that path, that we're going to ignore the book. We don't like Stephen King today. We're just going to absolutely throw that novel away, and we're going only with the film. Therefore, there is a chance that these may be visual hallucinations, which again is something the movie usually presents, or at least opens the door for discussion versus the novel. Organic pathology will remain a discussion point, a clinical concern, because of the rarity of visual hallucinations in mental disorders, including schizophrenia, schizoaffective, and delusional disorder. So that further emphasizes the need to do a quote unquote organic workup, and epilepsy would be part of that, right? It will be the same organic workup that we would provide for delirium and dementia for that matter, right? I Heart Lady Macbeth. How cool would it have been if they were watching Macbeth instead of Top Hat? That would have been a clever move to point us yet down this road. Substances. Next point of discussion. Are they playing a role here? So I want you to approach this question in two steps. One is, again, paralleling a real patient interview. That is, if you looked at the script scripts.com of the Green Mile. Are there any substances written into that script?
They drinking beer at some point. I'm trying to. It's about all I can think of.
Yeah. So minimal, right? And this would parallel the real patient interview, where we're getting that report directly from the patient. So it's a self-report. This is the patient keeping congruent with the film, telling us, an occasional beer. That's all we have.
Didn't they also drug Wild Bill though to get him to sleep?
Yeah. What was that drug?
I don't know what the drug was.
I don't think it's clear. They mixed it with alcohol, though, I think.
Yeah, some sort of sedative, but what year it was made, I mean, I feel like it can't be barbiturates or it'd be dead, right? I don't know.
I don't know. It depends how much they put in. That's something to potentially look up. It could be a benzo. It could be a barb. It is 1935. I would have to go back and look at the timeline here to see what that could. I'm wondering if it would be chloral hydrate, given the 1930s, right? Chloral hydrate, if I recall correctly, and this is well before my time, so no wisecracks here. But chloral hydrate in I think the 20s and 30s was actually included in drinks, and I think it was called a Mickey Finn, right? And I think that's where the terminology, slip a Mickey comes from. So it may have been chloral hydrate. So yes, maybe drugs do play a role. The idea here being, if they have access to chloral hydrate to drug Wild Bill, they have access to drugs, period. So we couldn't dismiss that everything we're seeing may be influenced by the direct and physiologic effects of a substance, specifically a substance in the sedative hypnotic class. Rule out, chloral hydrate intoxication. Of course, the withdrawal state could also induce psychosis as well. All right. Any other thoughts about the role of substances in the Green Mile? What is delusional disorder?
I'm not gonna have the criteria exactly right, but kind of what you were saying, where you have a fixed delusion, but every functioning remains intact, and um, pretty much everything that's off is related to the fixed delusion itself. Otherwise, like you said, functioning remains intact. There's no hallucinations. They typically don't hear voices. Behavior is pretty organized. And then anecdotally, I've noticed that like patients who do have that, seems to be those delusions are really hard to treat. Psychotic medications.
That's it. It's fairly straightforward. It's a condition defined through one or more delusions. It shapes up as a fairly straightforward diagnosis. The difficulty in diagnosing delusional disorder is really the workup that we just discussed in evaluating for and ruling out other conditions, larger conditions, if you will, that might explain the individual's delusions. So again, organic pathology, including medical conditions and the role of substances, as well as schizophrenia and schizoaffective disorder. So, and of course, even a primary mood disorder. If we think that Paul is acutely manic and his delusions are occurring during a manic episode, well, this is bipolar 1. And we treat bipolar 1. We do not call it delusional disorder. So we think of those larger illnesses, if you will, evidence of which I think here is lacking. That is, it's clear that we are watching and we are observing a case study of delusional disorder. Before we go to the next step, I want to briefly pause. Any feedback from anyone to the contrary? Have you picked up on something that is giving you a little bit of concern in pursuing delusional disorder? as our most likely diagnosis. I'll take that as a no. So we're all comfortable in pursuing delusional disorder as a provisional diagnosis, right? All right, so we have a basic understanding of this definition. The next step is to review the different subtypes of delusional disorder, otherwise referred to as themes of delusion, right? So what are the different themes or delusional themes?
You have jealous type delusions, like paranoid, persecutory type delusions, erotomanic delusions, grandiose delusions, and somatic delusions.
And then there's also two others that may or may not appear on your exams. Of course, it could be mixed, right? So individuals may not present with a single theme, but multiple. And I don't have the point prevalence for that, unfortunately, so I apologize. And then human behavior sometimes doesn't fit in these artificial categories either. So there might be evidence of a delusion that doesn't fit jealous versus persecutory versus other, and therefore unspecified. Okay, so give me some before we move on, because I don't think the Green Mile is a fictional case of delusional disorder unspecified. So let's talk about this a bit. Give me some examples of unspecified delusions.
We have Cotard and Capgras.
Good. What are they?
One is thinking that everybody around you's dead, I think, and then the other one is
The Cotard one is when you believe that one of your organs is missing, I think.
And Capgras is like believing your family members or like close ones have been replaced by others, imposters, right?
Good. And again, Cotard, otherwise referred to as the Walking Dead syndrome, not likely to come up in print on a board certifying exam, but it could help you remember. Walking Dead syndrome is the delusional belief that you or part of you is dead or dying, right? The Walking Dead syndrome. Capgras, on the other hand, is exactly what Mark said. It's the delusional belief that someone, it's usually someone close to you, has been replaced by an imposter. So it is also referred to as the imposter syndrome. So Cotard and Capgras. What is the Fregoli syndrome? A third example of unspecified delusion. Fregoli is the delusional belief that an individual can actually take the form of multiple individuals. So it's not necessarily an imposter syndrome per se, but it's a variant of that a single person can actually shapeshift. So it's also referred to as the shape-shifting syndrome, Fregoli. And then the final one that comes up on board, so there's usually 4 examples. Otherwise, I think titled Rare Psychotic Disorders, if you were to search it or find it in a medical text, rare psychotic syndromes, aka unspecified delusions, is reduplicative paramnesia, the delusional belief that you or a place exists in another area simultaneously. And that belief is causing you clinically significant distress or impairment. So the delusional belief that you or a place, perhaps your environment, has been replicated and coexists. So I don't want to get into quantum mechanics at this point and have anybody here with that background or major discuss that mathematically that could be proven. I totally get that. But usually our psychotic patients are not coming from that perspective. They're coming from a little bit of a different perspective, and they will usually show up at APS with other complaints as a product of reduplicative paramnesia, the 4th type of unspecified delusion. Is everybody okay in identifying that Paul really does not demonstrate any of these forms of unspecified delusion? Okay, I agree. So what's our diagnosis for Paul? What themes does he manifest?
Before we go on to the diagnosis, I just had one kind of question in terms of his formulation. I feel like while overall he presents like more psychotic than in terms of a mood disorder, one theme I kind of noticed in both the past and the present is kind of like survivor guilt and kind of like hopelessness, like just kind of thinking about like the depression criteria. So, I mean, I feel like there are times where he presents more psychotic without any sort of mood component. I feel like there is, though, throughout his life, an underlying mood component as well.
I think at first glance, we would say that that guilt does appear to be a product of his having known and his interaction with the events around 1930, specifically coffee. On the other hand, we have to be careful. We do know that there was an incredible experience he had, one that he clearly relates, but the clinical question, that is the question from any clinician would be, we need to talk about other prisoners. That was not day one on the Green Mile with regarding his vocation, regarding his work. He was there long before he ever met coffee, and might have there been another prisoner, another incident that basically was the etiology of his depressive disorder. So we'd have to ask that, or from another perspective, we'd have to create that prequel. So I think you're right. If anyone thinks that this is a product of those events that he relates, specific to this one prisoner, and that is true, but that doesn't mean that there wasn't a prior experience either. Remember, in psychotherapy, when you find the trauma, or you believe you find the trauma, always go back, because you will usually find a prior trauma. Very rarely is the information provided to us at the beginning of an interview, upon first watching a film, the whole truth. So always go back. In this case, we'd have to think of the prequel to the Green Mile. It's a good point. Mhm. And again, if we find something, this becomes a primary mood disorder with psychotic features, and it's a much different diagnosis with a much different treatment. If we saw the prequel and there is no evidence of depressed mood or dysphoria, anhedonia, loss of interest, or SIGI caps, and we are able to take our next step in further discussing delusional disorder, looking at the different themes or subtypes, do any jump out at you as being manifest by Paul? No? He's unspecified?
I would argue maybe grandiose, especially considering that maybe he felt like he was given the gift that was provided to him by John Coffey when they shook hands. So I think that would probably be towards the top of my differential as far as the type of delusion that I would be trying to attribute to Paul.
I completely agree. I mean, when he actually expands on his being 118, he kind of flirts with the idea that he's immortal. He talks about how much longer this is. He actually poses the question to Elaine. Makes you wonder how long this will go on, that I'm able to walk the earth. I mean, yeah, that's a little grandiose for me. Yeah, I completely agree.
And sorry to interrupt that, Toby. I think he also even says to her something along the lines of, I'm going to outlive you. I don't know if he says that. Does he say that directly to her? I'm not sure if I'm misremembering.
He says like, I'm going to end up burying you, or end up something like that.
Yeah.
I think
He does. He does say he has no illusions of immortality, but that's kind of what someone grandiose would kind of
Yes.
say to kind of downplay their grandiosity. So
Right, the whole quote may have been, "I have no illusions of grandiosity, or excuse me, immortality, but," right? This was the but. Right, I don't mean to offend you, but. One other thought here. You go back as you would collateral information and discover that there was never any coffee. No, John Coffey never existed. Does that reshape the way you want to go about thinking of these different themes? I'm worried about projection, right? I mean, did he create this character and project his id impulse onto the character? Because if that is the case, and if projection is something that is going on, projection, that defense mechanism that alleviates anxiety for Paul, then I'm also worried about somatic form of delusion. So this might be a mixed type. Remember, there are three subtypes of somatic delusion. Anyone know what they are? Dysmorphophobia, the delusional belief that you or part of you is misshapen in some way. I don't think that's going on here. Halitosis, the delusional belief that you are emanating an odor, bad breath, not likely going on here. And then infestation, the delusional belief that you were infected or infested in some way. And those scenes of the sin eater and how that's portrayed does look like infestation. So I know that happens to coffee, but if coffee never existed and we begin to think that projection is playing a role, that this is actually Paul the whole time, then this may be a mixed form of delusional disorder that is grandiosity and somatic, specifically that subtype of somatic delusion, infestation. Just a thought. And then in the 2 minutes we have left, briefly, we may want to consider that choice A, normal behavior, is what the Green Mile is really about. So has anybody investigated or studied the myth, the belief of the sin eater, right? The Welsh belief that certainly inspired Stephen King to write his novel. So in rural areas of Wales, there is the cultural belief that at or around the time of a funeral, there is a person with special powers who has a meal with the deceased family, and usually using crusted bread, is able to absorb the sins of the deceased, becoming sick themselves, but then cleansing the soul of the recently deceased so that it may enter the gates of heaven. Individuals who are sin eaters carry this burden, carry this guilt, carry this infestation, usually with a relatively short lifespan as a result of their gift/curse. If we learn that either John Coffey, if he does exist, or even Paul, if John doesn't exist, is of the same cultural belief, if he actually is from Wales, or if his family is and practices this very belief of the sin eater, then this might all be attributed to not a psychotic disorder, but a culturally sanctioned belief or syndrome. I don't know if it has a specific name other than sin eater, which of course is nothing that we would put in our medical record documentation, much less bill for, but we'd have to consider that this is actually all normal behavior. Final thoughts. All right, well, we'll close with the idea that this may all be normal, which is where we really should have started. But I didn't want to derail reaching our teaching objectives related to schizophrenia and other psychotic disorders. So, again, I can't make it next week, so I do apologize. I trust everything will go well. Any questions, let me know. Next month's film has already been sent to you in that Word file. Let me know if there's any concerns or any questions. Thank you.
Thank you.
Thank you.